Welcome again, everyone. This is Yasser Rasifi from Learn Dental series. In this episode, we will finalize our discussion about the topic of diagnosis and treatment planning by discussing how to design and assign suitable treatment plan for our restorative case. Let me declare that I don't receive fees, compensation, or royalties from the sales of any of the products shown or discussed. Also, this presentation has not been sponsored by any agency, company, or organization and is only prepared for educational purposes. Also, this presentation is copyright protected and content not be transmitted by any means unless you get a prior permission from the author. In this episode, we will try to design a proper restorative treatment plan. Already we discussed in our previous episodes about this topic. We discussed in part 1 patient assessment and information gathering in terms of demographic data, chief complaint, medical history, and dental history. Then we are going forward for clinical examination and diagnosis, including examination of dental caries, examination of existing restoration, examination of other tooth defects rather than caries, how to use adjunctive aids for examining teeth and restoration, examination of occlusion, examination of patient in pain, and examination of cracked tooth. Finally, we have now all the data that we could use in designing our treatment plan, and let us go to discuss how to design our treatment plan. In this part, you should hold this thought firstly. Always respecting the quality, we must offer to the patient different solutions focused on not what we want, not what they want, but what they need and we can. This is important, what they need and we can. We will start our discussion in treatment planning part by discussing what is prognosis, then the assignment of treatment planning, and interdisciplinary considerations when assigning our treatment plan. Let us start with prognosis. What is meant by prognosis? Prognosis is a term used to describe the prediction of the probable course and outcome of a disease or a condition, as well as the outcome of expected from our intervention or our treatment, either it is preventive or operative treatment. Prognosis is used to estimate the recovery from a disease or a condition, regardless the type of treatment, and also can predict the effect of this treatment in this recovery. In operative dentistry, prognosis can be used to describe the success of a particular treatment procedure in terms of time of service, how long it will last, functional value to the patient, then you are restoring tooth function, okay, in a comfortable way, okay, how much the comfort for your patient, he will not suffering from any complaints after you finished, and the aesthetic value for the patient. That's why you should refer to the main objectives of operative dentistry, to restore tooth function and occlusion by providing efficient and comfortable mastication. Okay, tooth function and occlusion, the functional is not only mastication but also it is speech, pronunciation of your letters, okay, regardless the language the patient use, and at the same time aesthetic is a major function, especially for anterior teeth, and the efficient and comfortable mastication. Okay, prognosis can be scaled and described as excellent, good, fair, poor, or hopeless. Okay, the dentist should discuss all the expected prognosis of the case and what is his responsibility and what is the patient responsibility that plays major role in the prognosis of the case. Okay, who is responsible about what? Okay, the responsibility of the dentist is to perfectly design a cavity or perfectly design a treatment plan and perform it perfectly, but this is not end of story. The story at this point started to be the responsibility of your patient. That's why you should clarify this to him, what he should follow, either instructions or hygiene measures, or what he should modify in his attitude, and what is the frequency of maintenance visits and the interval of maintenance visit, each one in this party should know and get a clear vision about what is his responsibility in the prognosis of the treatment and how to perform this. Okay, and accordingly, the operator should describe to the patient in a scale what the expected prognosis in each condition. Excellent prognosis means that you performed all your job, okay, in a perfect way, and the patient also performed his job and his responsibilities in a perfect way, and so on. Okay, all of these should be clear in a verbal and a written prognosis form. That's why it comes the importance of informed consents, and the patient should sign a consent in certain cases where the responsibility in prognosis lies on him. Prognostic indications includes two main factors, tooth level factor and the condition itself. Tooth level factors in terms of restorability, status of the bulb, and status of periodontium. This should be carefully evaluated in clinical examination and should be clarified to your patient. You should use all the available adjunctive aids to determine tooth responsibility, status of the bulb, and status of periodontium. Restorability that entails, can operative treatment be used to repair and reinstate the tooth structure successfully in mid and long term? This is a question that should be answered by determining the restorability. Okay, and that is what is the benefits, what is the rationale of your operative treatment. Does it ensure that it will repair and reinstate the tooth structure successfully in mid and long term? Okay, this could be estimated by the severity of damage of the coronal hard tissues, extent of the carious lesion, the amount of tooth structure lost due to other than carious lesion like trauma, tooth wear, or developmental defect. This could be calculated and determined exactly according to the clinical examination and the severity of damage of the tooth. Then comes the status of the bulb. As long as the tooth is vital and normal, okay, and its sensibility within the normal, this indicates a good to excellent prognosis. Status of the periodontium, including alveolar bone levels, periodontial ligament, mobility, oral hygiene measures, all of that, okay, with the extent of damage and how it reaches, or how is its relation to the biological width, all of that could give a good estimate about the expected prognosis of your case. Then comes the condition itself as a whole. Okay, how much the ease with which the etiological factors can be removed or modified to prevent or slow the progress of the disease and its recurrence. Let me give you an example. If the patient having a xerostomia, okay, dry mouth, is this xerostomia is due to medication or localized condition, okay, or it may be due to radio or chemotherapy, okay. If the patient having this xerostomia due to radio or chemotherapy, then the prognosis is much more complicated and tends to be poor one. But if it is due to localized factor or due to patient habits that could be modified and could be retained again to normal, okay, then the prognosis will be good. But in general, presence of xerostomia always tends the prognosis to be lower prognosis or tends to be poor. Okay, that's why it should be modified first. If it cannot be modified, then your prognosis will be poor and the patient should be informed about this. The prognosis may be improved even if the carious lesion is extensive to a cause or another, but it could be improved if the patient is receiving a fluoride therapy, an oral hygiene maintenance therapy, and the patient is following the instruction. Okay, that's why the second item related to the condition itself is the degree of patient motivation to manage the condition. Okay, that's why we are recording in our demographic data the oral hygiene habits, the history of the past dental history, the frequency of prophylaxis, the frequency of visiting dentists, and education and occupation of the patient that reflects the degree of interest, and even if he is not interested at the at this time at the time being, but how much he could be motivated. Okay, that's why you could avoid further tooth destruction by preserving his teeth, okay, by following the instruction, okay, and all of these should be documented fully in your clinical notes. Then comes the treatment planning. To develop a dental treatment plan, you should follow 4 steps for gathering all the data. Okay, number 1, examination, problem identification, and risk assessment. This is what we had discussed in 11 episodes before this one, okay, including demographic data, including history of the patient, including clinical examination of all interesting items in our diagnosis. Then comes decision to recommend intervention. According to all of these data, okay, what is the decision, okay, to intervene this case or to treat this case? Third, is there any alternative managements? What are the alternatives and what are the benefits, the cons and the pros of each alternative of our treatment? Then selection of the treatment with the patient involvement. All of these should involve the patient in our discussion to select what treatment and what is the treatment alternative, what is the best one and what are the alternatives, and discussing all the advantages and disadvantages and discussing what the instructions should be followed for each treatment option. Okay, then all of these are influenced by 2 main factors. Factor 1 is the patient himself, and factor 2 is the dentist who will perform this. The selection of treatment option will depend on patient preferences, motivation, systemic health, emotional status, financial resources also is an important issue, okay, and functional, aesthetic, and technical demands the patient needs. Then comes the role of dentist, including his knowledge, experience, and training. What is the laboratory support he have or he dealing with, dentist patient compatibility, availability of a specialist if you are in need for other specialists to perform other treatments that will help you to perform your restorative management, like periodontist or orthodontist or endodontist, that we will be discussed later in the coming slide. And also the patient functional, aesthetic, and technical demands. Please don't fail in the trap of you are obeying the patient needs regardless your skills and experience, because nowadays most of our patients are searching, googling most of the treatment, and they thought that all the available treatments are suitable for him, like patients that are asking for lewd smile or different smile designs. Regardless, when you are advising him to go for periodontist first, okay, he may not understand the importance of periodontal condition management before going for that condition, okay, and he thought that all the cases, especially his case, is suitable to go for this, and finally he will blame only you, not himself, when the restoration fails or the treatment fails. Then, treatment planning, we have 2 types of treatment plan: ideal treatment plan and optimal treatment plan. Ideal treatment plan, where the best ideal treatment is performed, okay, regardless or irrespective to the patient and dentist limitations. This is not truly applicable except for dental colleges or educational hospitals, okay, because you have an operator, which may be a post or undergraduate student who would like to practice all the best treatment regardless his skill. He is already in a condition, he would like to know how to perform this under supervision of consultant or instructor. At the same time, the patient limitations are nothing, because the treatment is offered for free. That's why it is the only situation where it is applied as ideal treatment plan. Okay, the only limitations in this condition is the facility limitations, okay, of this property or of this hospital or of this college. Okay, and I think it is by a way or another it is a limited time limitations, okay, not forever. Okay, then comes the actual clinically practiced treatment plan is the optimal treatment plan, where the maximum form of treatment, okay, or treatment option is done in relation to the patient general and oral conditions, as well as the dentist knowledge and experience. Okay, this is the most commonly used. That's why we mentioned in the previous slide that there is always alternative treatments. There is no only one option in treatment. If there is one option in treatment, then this is the limitations of the dentist, because he doesn't know any other alternatives. He is just focusing in only one way. He is focusing in amalgam restoration for posterior teeth because he is not trained on posterior bonded restorations, or he is trained but haven't any equipment or material to perform it well. Okay, that's why you should hold this thought. The success of the treatment plan is determined by its ability to meet both patients' initial choice and long-term needs. Okay, initial needs now and long-term needs now. This is the successful treatment plan. Okay, that's why we don't have only one treatment. Always we have treatment alternatives or treatment options. Treatment plan should follow certain phases and sequence. Okay, treatment plan is not a static list of service. It's often a multi-phase and a dynamic series of activities. You could use all your critical thinking skills to design a roadmap to get a successful prognosis and a successful treatment of your patients. This is the treatment plan. It is the roadmap to achieve your goals of restorative treatment and achieve the patient target and goals also. That's why it is a dynamic, not a static, not a sequence of steps. What is meant by dynamic? Dynamic means that you should assign certain stops every now and then to evaluate your treatment and evaluate your outcome before proceeding to the next step. Okay, in certain cases you may go back too many steps just to re-evaluate or redo a treatment. Okay, especially for periodontal treatment. Let me give you an example. Okay, you are excavating a severe or extensive carious lesion. You are temporizing it with fluoride releasing material and refer your patient for periodontist. The periodontist finished his job carefully and perfectly, but the patient didn't follow the instructions and didn't maintain oral hygiene. If you are designing a static sequence of steps, then the patient came to you again, okay, will come to you again, and you will replace your fluoride temporization with final restoration regardless the condition of oral hygiene. But if it is a dynamic treatment plan, then you should assess the oral hygiene again and the periodontal condition again. That may drive you to refer the patient again to the periodontist, or let the patient again follow the oral hygiene, or force him or motivate him by a way or another, but don't go for final restoration unless you make sure that your periodontal condition is fair enough to ensure proper diagnosis. That's what is meant by dynamic, that you have definite stops every now and then to evaluate your treatment, evaluate the perception of patient to your treatment, evaluate the degree of motivation, and if you are continue to the next step or go back or just wait to control the condition. Okay, that's why proper sequencing is a crucial component of the successful treatment plan. Okay, certain treatments also may follow others in a logic sequence or order. Other treatments can be or must be occur concurrently and require coordination or may be parallel to each other. Okay, it differs according to your case and your assigned treatment plan. Phases of treatment plan are mainly five, okay, which is termed urgent or emergency phase, control phase, re-evaluation or holding phase, definitive phase, re-care and reassessment phase. In certain simple cases, like that of simple occlusal cavity in a patient with a favorable good oral hygiene and a favorable state of occlusion, then you could join all phases together to go for definitive phase immediately and then come back for follow-up for re-care or assessment. That's why most of the patient in operative dentistry treatment planning, the first two phases are joined with each other for a single case. For a simple case, I don't have emergency, I don't have to wait for control phase, I don't have to re-evaluate the case or have a holding phase because the bulb is already vital, the tooth is vital and the periodontal condition is fair and the occlusal condition is fair. Then in the same visit, okay, we could neglect all those three phases and go for definitive phase, including cavity preparation and restoration in one visit. Then the patient will come for follow-up as assigned by the dentist. Let us start with phase 1, urgent or emergency phase. The patient at this condition may present to you with swelling, pain, bleeding, or infection that should have to be management as soon as possible before initiation of subsequent phase. Regardless, this is the ideal or the best treatment or not. This is an emergency management, okay, that should begin immediately after reviewing carefully your patient medical condition and history. Okay, then comes the control phase. What is the control phase? Control phase, the time needs formally to control to control some treatment. Like that, I am waiting to pain to subside in emergency phase. Okay, I am waiting for bleeding to stop. I am waiting for medication to get some action in certain cases. Okay, but this is if the case is emergency. But if the case is normal, okay, maybe the patient present with multiple problems like extensive active disease, the prognosis is unclear. That's why I would like to eliminate the active disease, such as caries and inflammation, removing conditions preventing maintenance, eliminating potential cause of the disease, beginning preventive activities such as periodontal debridement and scaling, occlusal adjustment, caries removal and temporization, either with fluoride containing temporary filling or not, replacement or repair of defective restoration, use of caries control measures. Okay, after that comes re-evaluation or holding phase. At this phase, okay, it is the time allowed between the control and definitive phase for resolution of inflammation or for healing. Let us say that you are applying a calcium hydroxide just to sedate your bulb or zinc oxide to relieve pain of reversible bulbitis. Okay, the time consumed for relief of this pain is called the holding phase. If you are subscribing for your patient an antibiotic or analgesic, just advising him to use it for 2 or 3 days, whatever the time you assign for him. Okay, just waiting this drug to get its action, it is considered as re-evaluation or holding phase. Then home care habits are reinforced, motivated, and further treatment is assessed, and the patient should be reassessed for the bulb response, relief of pain, stop of bleeding, what are the home care he is following before going for definitive phase. After that comes the definitive phase. It is called definitive because the definitive treatment is done. This definitive treatment may be restoration, may be endo, may be ortho, may be prosthodontics. And this definitive treatment may be a single visit or maybe up to 1 to 2 years like that for orthodontic treatment, okay? It is the starting of the actual treatment for solving the patient problem by the most reliable treatment option, okay, to achieve the goals of your treatment plan for you and for your patient, okay? It may be a single visit, maybe multiple visits, and how long it does take, okay, until you finish your treatment. But in multidisciplinary cases, or cases of operative dentistry that may involve multiple quadrants, I advised you from my experience, okay, and from my opinion, what I always like to do is to determine, even at this definitive phase, definite stops to assess the treatment you have done. Let me discuss it with you and clarify it to you, okay? If you have even a simple cavity preparation for just only one tooth, and this is all the case, even with this visit, you should have definite stops, okay? These stops including, number one, drying the cavity and inspecting the presence or absence of your caries. Did you remove it correctly or not, okay? Another stop, okay, is before applying your material, you should inspect your cavity. And are you following the basics, okay, or are you preparing an accurate cavity or not, okay? If suppose you have to go for bonded restorations, then you have definite stops for itching. You should reevaluate. You should reevaluate your bonding procedure. You should reevaluate the curing of your first increment of composite. You should, before of all of that, you should assess the matrix if it is a compound cavity. Even if it is a single visit, you should have definite spots to reassess your procedures and the accuracy of your procedures. Either it is a single tooth restoration, quadrant restoration, multi-teeth restoration, or multidisciplinary restorations. All of these should be assigned in your treatment plan. Then comes the last phase, which is recare and reassessment phase. Reassessment phase, it's a regular evaluation and examination follow-up of your case to reveal the need for adjustment to prevent future breakdown and provide opportunity to reinforce home care. Let me give you an example. You need, especially for bonded restoration, to scallop restoration and posterior teeth. It is difficult in the first visit when you finish your restoration in certain cases to determine if the patient is having a premature occlusal contact or not that need occlusal readjustment, especially if the patient is anesthetized with inferior alveolar nerve block, okay, that will not enable the patient to bite correctly and determine if there is a premature contact or not. Then you are in need for reassessment, okay, and follow-up visit, one immediate within few days and one according to the severity of the case and the risk value of the patient according to the risk assessment. That's why the frequency of recall during this phase will depend on the patient risk for dental disease. Number one, you should offer him a recall visit within few days just to follow up your treatment, your restorative treatment, for accuracy of following up the instructions and for re-examining the occlusion, finishing and polishing, and there may be some rough areas that may irritate the tongue or the cheek of your patient. Just a minimal recheck again, okay, just for a few minutes. But patient for low risk, okay, you may need to re-evaluate him every 9 to 12 months. But patients with high risk, okay, you need to see him much more frequently, maximum 3 to 4 months, just to reassure that he is following the hygiene measures that will lower the caries risk of the patient. What if you are a part of interdisciplinary, comprehensive, complicated case? Then, in such a condition, okay, the definitive phase will be too much crowded with much disciplines. We should have general guidelines, who should start first, okay? Who will prepare the case for the other discipline, okay? Is this treatment is the responsibility of whom? It may be the responsibility of mine, but its success and the prognosis is the responsibility of other discipline. That's why we should have guidelines in the definitive phases and control phases in cases of multidisciplinary, comprehensive, complicated cases. Okay? The relation between operative and endodontics. All teeth with large restoration should have bulbal and periapical evaluation unless you finalize your treatment during cavity preparation, during temporization. After you temporize this case and the patient came to you for the next visit, start with bulbal and periapical evaluation. Again, it may undergo changes, pathological changes, okay, and you couldn't recognize it, and your patient also couldn't recognize it. If indicated, okay, teeth should have endodontic treatment before restoration, okay, because restorative procedure will be much more complicated if you need endodontic intervention in between your treatments. That's why finish firstly your endodontic treatment, okay? Tooth with a previous endodontic treatment that show no evidence of healing or has an inadequate filling or a filling exposed to oral fluids, okay? Endodontic fillings and the fillings exposed to oral fluids should be evaluated for retreatment. That's why when you are performing a coronal restoration for a previously endodontic treated tooth, you should ask the patient for how long he finished this endo treatment, and what about the TF, it is integral or not. Once the TF is soluble and washed away, then reconsult your endodontist for retreatment or not, and re-evaluate the case before you seal it with coronal restoration. But the major relation between operative and other discipline is between operative and periodontics, and already we gave an idea about it in previous episodes. Generally, periodontal treatment should precede operative care, should precede all disciplines care, okay? Especially when improved oral hygiene, including initial scaling and root planning procedure, can create a more desirable environment for performing operative treatment. As we discussed before, a few minutes ago, that the success and the prognosis rate is depending upon to how much the fairness of your periodontal health and how much your patient is following oral hygiene prophylactic measure. A tooth with a questionable periodontal prognosis should not receive any extensive restorative management until periodontal treatment provides a more favorable prognosis. A tooth that has a good periodontal prognosis, operative treatment could be performed before or after periodontal therapy, as long as there is no interfering between them, okay? The operative treatment is not compromised by existing tissue condition, and the periodontal condition is not compromised by the operative condition. Let me give you example: a patient having a staining and plaque and calculus accumulation in anterior teeth, especially the lingual surface of lower anteriors, or was showing plaque and calculus accumulation in most of patients, okay? But the patient at this time, okay, is under periodontal therapy, and at the same time he is referred to you because of simple occlusal caries in upper or lower molar in area, not interfering with periodontal therapy, or periodontal therapy not interfering with it. That's why you could go for parallel treatment, operative and operative and perio, okay? Because both of them are not interfering to each other, and both of them, no one of them is responsible for the prognosis of the other. Treatment of deep caries lesion often requires caries control, foundation, and temporization of root canal therapy, or both before periodontal therapy, even if it is temporization. Also, correction of gross restorative defects in restoration contours is considered as a part of initial periodontal therapy, as it enhances a favorable tissue response. If the condition of periodontium is getting worse because of improper contouring of a restoration, then restorative management should come first. That's why the case should be evaluated. Who is affecting whom? Okay? If the operative is interfering with the prognosis of periodontal therapy, then operative comes first, because the environment should be favorable for periodontal therapy prognosis. And vice versa, if the periodontal treatment interferes with proper operative or restorative treatment prognosis, then it should come first to alter the environment favorable for successful restorative procedure. In certain cases, if periodontal surgical procedure are required, permanent restoration, are required. Permanent restoration such as inlays, onlays, crown, and prosthesis should be delayed until surgical phase is completed. But simple restoration could be finished. Teeth requiring restoration that may encroach on biological widths, as we discussed before, of the periodontium, should have appropriate crown lengthening, surgical procedure performed before final restoration is placed, just to clarify where is the level of your gingival margin. Usually, a minimum of 6 weeks is required after surgery before final restorative procedure are undertaken for proper healing. Orthodontics. It's clear that you shouldn't start orthodontic treatment unless the cases are caries free. It's a big rule, obvious big rule. All teeth should be caries free before orthodontic banding, because already orthodontic banding adding more areas, more shelters to stagnate food, microorganisms, carcinogenic microorganisms, plaque accumulation, all of that, especially if the patient didn't follow the instructions of the orthodontist to maintain his oral hygiene. That's why when your orthodontic patient with bands or braces is not following exactly and neatly the oral hygiene instructions, it will be a disaster when the orthodontist remove these braces or these bands. That's why treatment of caries, which may include placement of amalgam or composite restoration, and sometimes cast restorations, should be finished before orthodontic treatment is completed. And patient undergoing orthodontic treatment should receive more intense caries prevention measures and program. When considering oral surgery, all impacted and erupted and hopeless teeth, should be removed before operative or restorative treatment. This recommendation especially applies when second molar that are to be restored might be damaged or dislodged during removal of third molar, because the operator may rest his elevator and damage your restoration or destruct a cusp or another. Soft tissue lesions should be eliminated or corrected before final restoration, and at least also 6 weeks are required after surgery for proper healing of your wound. In such a case, the spine showing that your cusp, your mesial cusps of lower third molar, are impinged under the cervical line of second molar and causing distal caries. In such a case, if you review the clinical condition, okay, which comes first? Class 2 for proximal surface, distal surface of the second molar, or surgical extraction of the partially impacted third molar comes first. Surely the partially impacted molar should be extracted or removed surgically first. Why? Number one, why you limit the access to area? Why you decrease the visibility to your area? How could you examine your gingival floor? How could you examine the proper removal of your carious lesion? How could you get access, easy access to this condition? This is number one. How could you apply matrix for restoration? How could you apply perfectly and back your cavity with your material of choice to restore it? Okay, how could you ensure that you restore the proximal contours of your tooth, your cavity, twice, while your cusp is impinged inside this cavity? All of these factors should be considered. Even if it is easy for you by your experience or by your skill or by any way, okay? What about the surgeon when he is trying to decapitate this tooth and applying his elevator? At this time, he may displace or dislodge your restoration, and surely one of your cusps or one of your margins will be distracted, and your patient may not note this. Okay, that's why let the surgeon extract this tooth, okay, and wait until your gingival tissues are healing well and the socket is healed well, okay, and you will clearly and accessibly could gain proper access and visibility to your lesion. You could properly apply your matrix, you could properly condense your material, and you could properly reproduce your anatomical features of this proximal surface. Finally, what about fixed, removable, or implant prosthodontics? Operative direct restorations should be completed before placing indirect restorations. In general, all dental treatments under any specialty should be completely finished before you are going for the prosthodontic phase. Prosthodontic phase is always coming the last one. Everything should be clear, all the treatments should be finished, all tissues should in a good condition, should be healed, okay? Then comes your prosthodontic management, okay? Restorations such as foundation, retentive features must be placed well inside your cavity and inside your restoration in order to not to gain withdrawn during the preparation of the fixed prosthodontics or the fixed crown. That's why you should clearly inspect your retentive features to ensure that your material will not be displaced during preparation of your crown. Also, your tooth preparation should allow for the design of removable partial dentures, should be considered well, okay? If the patient, especially if you have a case with carious teeth and in between there is an edentulous span, you should firstly ask your patient, how are you intended to restore this edentulous span with a prosthodontics, and which type of prosthodontics you are planning to get, okay? Because this could already affect your decision, restorative decision. Suppose you have just a simple bits and fissure caries, okay, and this tooth will be an abutment to retain a full coverage retainer for a bridge. Sometimes your management will be nothing, because as you detect it as E1 or even E2 in your radiographic notation, but it will be absolutely removed, okay, while you are going for occlusal reduction of this abutment tooth. That's why you are not need to prepare anything other than this. You are wasting your time, your material, and patient time, and also patient fees, okay? At the same time, which is most important, you are sacrificing too much tooth structures in depth because you will be in need to go forward after dentine enamel junction for at least 0.5 millimeter, while this carious lesion may be completely eradicated with occlusal reduction within enamel. Okay, that's why when you have an edentulous space, you should ask the patient first, okay, what's your plan for restoring this edentulous space? Okay, if it is a partial denture, okay, then you should refer the case for periodontist for the design of partial denture. Does he need to put an occlusal rest seat in this tooth? That will affect your choice. Okay, and what is the recommended material? He should recommend to you a material for restoring this tooth at this time. Okay, or the case is planned to be restored with implant. Then when it is restored with implant, you just, if it is an occlusal cavity, okay, just go straight forward for the selected restorative management, okay, or the selected restorative operative dentistry. But if it is a proximal lesion, you should consider and reformulate your contours and exactly and perfectly, okay, as the natural one, okay, and sometimes you should ask if the prosthodontist or the implantologist requires some modification, okay, in the surface, okay. That's why I reassure again that the design of operative restoration and selection of appropriate restorative material must be compatible with the design of your removable and fixed restorative management. Finally, we finished our discussion about diagnosis and treatment planning. I hope you could understand it. I hope it will be beneficial for you by any means, and I pray to Allah I may add any knowledge to you in those 12 episodes. Finally, those are my textbooks I used. Those are handouts for International Caries Classification and Management System, that for ICDAS and that for Canberra. They are available for free online. You could download it, okay, and follow up if they have any update. Finally, feel free to ask me at any time, as your questions are welcomed 24/7. You could ask by commenting to this video and I will reply to you as soon as possible. Also, you could email me and I will, by any inquiry, and I will reply to you as soon as possible. I would like to thank you to assign this time to listen to me, and I would like to remind you by subscribing to my channel and activate the notification to get all the new updates. And finally, don't forget to like this video. Thank you again. Yasser Al-Wasifi, until we meet in another